off somewhere, oops, somewhere in the middle towards the end. So I'm actually going to just, I don't know, Elizabeth, if you, because I can't click ahead, if you can just keep clicking forward until we get to the case study. Because we went through most of it. And then I had kind of just expanded on our case study today, just since we didn't have a case to present. I thought I will just present one instead. I want to say it's the slide after the decompensated cirrhosis. I think the next one. Yep. Okay. All right. So I hope I set this up right, because I'm not good with PowerPoint, and I kind of just added a bunch of stuff in right before the session. So I am hoping this can be interactive. I want you guys to chime in, and we'll kind of go through this guy together like we're both just seeing him for the first time. But this is a gentleman that first became known to me back in 2017. So he's a 55-year-old Caucasian male with past medical history of neurocognitive disorder secondary to a traumatic brain injury, chronic alcohol use, seizure disorder, and schizoaffective disorder, who has been a resident of a long-term psychiatric facility since 2015. If you click, or actually you can, I don't know if you can let me click, maybe I'm on my phone, but then I can click through them. Yeah, so his labs, these were the labs that came with him on his referral. So his facility had already obtained a genotype, viremia, and fibro test. He was genotype 3 with baseline viremia of 1.2 million. Fibro test showed F1 to 2 with A0. His white blood cell, and I'm only putting the pertinent labs on here, but CBC was pertinent for white blood cells were 3.8, hemoglobin 11.6, and platelet count of 100,000. AST was 37 with the normal reference value or upper limit of normal of 42, ALT 38, ALP phos 79, T-Billy 0.7, albumin 4.2. I think 2 more clicks and we should have all the lab data. INR of 1, sodium 142, and creatinine of 1.1. So I'll just poll everyone with this information. What would you guys want to know next, or what would you want to calculate next? What further data would you want to obtain? Anybody want to chime in? Because I want this to be interactive, so we can kind of learn how to manage these patients as a whole. If you haven't presented any cases yet, it would be good to get started with this, or type it in the chat. I don't really care. Nobody? Bueller? Anybody? Okay, so what I was hoping you guys would say was, I guess go to the next slide. Was, what's his HIV status? What do we want to know about him? So he is HIV negative. His hepatitis B serology was pertinent for his core antibody was reactive. Surface antibody did show good protective immunity with level of 18. And then he actually had record that he'd received both hepatitis A immunization. So we could say he's vaccinated. What else do we want to know? Do we want to know anything about him? Like, what's his life story? Probably. Greg Peters wants to know about his life story. So go ahead and click to the next slide. So he's disabled. He had a prior career as a roofer. He's divorced with 2 adult children. He was diagnosed with, and he's not the best historian. I mean, he still would, tell me that he was working on jobs and roofer, even though he'd been, in a long-term facility for a while. But he had said he was diagnosed with hepatitis C about 10 to 12 years prior to when he came into me in 2017. And this was while he was living in South Carolina. So no prior records from that, just the records from his psych facility came with him. His risk factors said never, no IDU, never, not even once. He didn't have any other additional risks besides tattoos when he was in his 20s and 30s, and then also some intranasal drug use as well at that time. He did have a pretty heavy alcohol history, 12-pack per day of beer for at least 30 years, I want to say. And then he would say on good days, he couldn't remember. He just, on good days, he wouldn't be counting. It's kind of what his reference was. But since he'd been at a residential setting, he had not drank alcohol, so none since 2015. No pertinent surgeries, family history, had some cardiac disease and mother's side, but nothing related to liver or hepatitis, anything like that. And then only allergy listed was Depakote. So next slide, please. So his only complaint, he said his energy was great. He was feeling good. He really didn't say anything other than he had mentioned a 50-pound weight gain since his psychiatric admission. Review of systems, he noted that he bruised easily, but had appetite loss, adenopathy, wasn't having any night sweats or problems swallowing, never recalled any jaundice or GI bleeds, no abdominal distension or swelling, edema, itching, and everything else seemed to be negative. He didn't recall any history of decompensated liver events, such as variceal bleeding or ascites. He kind of has baseline confusion anyway. He had this traumatic brain injury and then also from his long-term alcohol use. So his baseline was kind of confused regardless, but from the staff members that were with him, nothing above his baseline. So without moving forward yet, what do you all think in terms of his liver status? Since this is really, this talk is really, or was really based on, why genotype and fibrosis matter. How do you feel in terms of his fibrosis status? Do you think that he is, early stages? Should we calculate an APRI or FIB4? Should we get imaging?
Imaging.
Thank you, Jen. Good. Okay. Yeah, I mean, in this gentleman, I certainly would. His fibro test was very reassuring, F1 to 2. But if we looked even just at his platelet count, where he's has mild leukopenia, he's got thrombocytopenia, well, really pancytopenia because his hemoglobin's low too. And so, if we were to calculate his APRI, I believe I calculated it was 0.8. And then his FIB4 was greater than, I think it was 3.3. So anything greater than 3.25, you have a pretty high positive predictive value for cirrhosis. So even though the fibro test was reassuring, we've got enough data to say, hey, we should look a little bit deeper. So next slide, please. All right. So his ultrasound, it showed that the overall echogenicity of his liver was increased. The contour was lobulated with echo texture coarsened, not any focal lesions identified. There was a note of dilation of his portal vein, and then his periumbilical vein was recannulized. Otherwise, imaging was unremarkable. So with this finding, I mean, I feel like we would be much more confident at saying this patient does have advanced liver disease and even cirrhosis. If you go to the next slide, Elizabeth, I pulled up those risk factors associated with HCV liver progression again. So if we're looking at host factors, like I said, we didn't have an elastography on him. We had a fibro test. We just weren't able to get elastography. And I feel like often that's a limitation in West Virginia's access to that test. But, his fibrosis and inflammation grade were actually pretty optimistic, but his kind of on the downside, he's male sex. He had a long-term history of alcohol consumption. Looked like from the increased echogenicity, he's got, at least some kind of steatosis there. He'd had a 50-pound weight gain, which honestly would be concerning to me, even for ascites. But I had talked with his staff, and actually he was pretty cachectic when he came in. He'd actually been homeless prior to his admission. So that was actually a good weight gain. So that was from eating regularly, not anything concerning or ascites. So no diabetes. He was not obese. He does have genotype 3. So he's got, multiple factors that could be associated with hep C liver fibrosis progression that could deem him as cirrhotic. On top of that, he's got this history of 20 plus years of having untreated hepatitis C virus as well. So if we go to the next slide, other things to know. So he's treatment naive. I'm not concerned for alcohol or drug use or any ongoing risk factors. He's in a controlled, supervised environment. So he is somebody I would want to treat. I calculated his child's Pew and MELD, which I was hoping we could do that together, but we don't have to. And so if you click again, he's child's Pew A. and MELD of 7. So pretty compensated liver disease. Is this somebody that you would get an EGD on? Or do you not think that that's necessary in this patient? So we have somebody that liver imaging findings, because there's some that kind of suggests this portal hypertension, so collateral circulation. So his umbilical vein was recannulized, his portal veins were dilated. So we've got some evidence of this portal hypertension, which really varices is a complication of that. And so in this case, I would certainly get an EGD. Remember, we talked about last time that we don't necessarily have to get an EGD in everyone that has cirrhosis, because we're really trying to weigh on the probability of whether they have varices or not, or if they're at a risk of bleeding. And so if you have access to a liver elastography, really, if their median value is less than 20 kilopascals and their platelets are greater than 150,000, their risk of variceal bleeding is very low. So you don't necessarily have to get an EGD, quickly. But in this gentleman's case, we didn't have an elastography. We have evidence on his imaging, even without getting elastography, of portal hypertension, and his platelets are 100. So he certainly is somebody that I would get one on. I think when I redid this case study this morning, I took off the findings, but he actually did have trace gastric varices. And so he was started on nadolol, but nothing needed banded. He didn't have any bleeding. Next slide. So his medications are listed below. And like I said, we added nadolol, and he actually was already on lactulose when he came into me, which if I'd seen that on his med list with not knowing, much about him baseline, and him complaining of this weight gain and him having this confusion, I would have wondered, does he have decompensation? That's your next question. But we really did that. We calculated his MELD, his child's Pew, which, remember, those are prognostic factors in determining, liver cirrhosis stability. And so that's a 90-day, mortality. If their MELD is less than 17, it's less than 2%. So he's pretty well compensated. Even though he had varices, he didn't have any bleeding. So that would be a decompensating event if they were bleeding, but his were not. They were just detected. But I found out that the lactulose actually was added not because of concern for encephalopathy, although he may have had that too. It's hard to sort out with his baseline confusion, but he actually, his ammonia levels increased when he was on the Depakote. And so they had stopped that, but also started lactulose concurrently to try to reduce those levels. And so he was remaining on that. Jen, you got a question? No? Okay. I saw you pop up. That's why I wasn't sure. Yeah, I want you guys to talk. Please interrupt me. So, we would classify this gentleman as compensated. And I just, if you remember, it's the patients that are decompensated that we really worry about treating them in a primary care setting, or at least, the very least, without having a transplant evaluation or having a hepatologist or gastroenterologist on board to help kind of manage the stability of their cirrhosis. So go ahead and go to the next slide. I'll tell you what I did. So I initiated Epcluse on him for 12 weeks, and this was back in January 2017. He actually didn't come back for a while. He came back in August, so several months later. He should have finished his treatment around, I guess, end of April. But the reason he didn't come back was he had actually transitioned to another psych facility. And so they brought records with him dated February, so that when he was about a month into treatment, and they showed his hepatic panel was still stable, and HCV PCR was less than 15. And so the reference value, the threshold for their reference lab wasn't not target, not detected. It actually was less than 15. And so that would have been about his treatment week 4, around that time, viral load. I wasn't able to determine when he actually completed Epclusa because his outside med rec list still listed it as an active medication. I did find out a little bit later that he'd had a 2-week treatment interruption sometime between when he was transitioning facilities. So you can go ahead and I went ahead and got a follow-up PCR at his visit, and go ahead and click, we can see what it was. So it was actually about 359,000. So this was several months after he should have completed his treatment course. And yeah, that was the part I was saying about how I had determined he had a 2-week treatment lapse or treatment interruption. He ultimately finished 12 weeks just with a 2-week lapse. So did I forget anything? Was this a treatment failure because he'd had that couple of weeks off of therapy, or was there something that I should have done differently as far as my initial testing?
Don't be shy. It's a safe space.
Please don't be shy. It's just me.
And Jay, I mean, come on.
I know, right?
I know, seriously, I'll
Jay,
hop
come on.
off. I feel like I'm the one who's
and
not
the
letting the group go.
silver fox and the silver fox.
Are you sure he was treatment naive? I mean, I found myself wondering about really had accurate history.
Great question. Right. So yeah, so as far as I can tell, he would have been treatment naive. To be honest, he had not been in a long-term care facility. I mean, he had been since 2015, but prior to that, he'd had very transient housing. So I really err on the side of he probably was treatment naive. I don't think his mental status would have been stable enough for him to go through interferon. And in 2017, we didn't even have Maverick yet. We really had Epclusa was our only pangenotypic. So he really wouldn't have had great direct acting options to where I think that he would have been in a place that he could have had treatment. But yes, that's a great question. I don't believe that he would have.
I also wondered about medication interactions. I'm sure you ran them, but I was just curious whether anything showed up.
Yeah. So, and Rachel, you can chime in too. I mean, so the couple that we think of when we're just kind of glazing over the list, I mean, I always encourage, still run an interaction report, even if it feels run of the mill to you. But, some of the ones I wouldn't have been as familiar with and definitely wanted to check into was the amantadine, which seemed to be okay with the Epclusa. Certain anti-epileptics can interact with Epclusa, but he's on Keppra, which was actually one that we can use. And so, no, there weren't any interactions. I was, most concerned that it was because he had been off of therapy for 2 weeks, even though he ultimately did finish the full course. Any other thoughts before I go on? Because I forgot a big thing.
I don't know if this has anything to do with anything, but I was wondering what his Hep B immunity was.
Oh yeah, no, that's great. So his core, he had core positivity. His Hep B surface antibody was 18. Okay. So he did have protective immunity to where he didn't require any further monitoring.
Okay.
On treatment, but yeah. So go ahead to the next slide, Elizabeth. But the big thing I forgot was resistance testing. And so I know kind of Dr. Gilfus and I glaze over this, whenever we're talking about treatment regimens, we tend to bring this up in 2 instances. Typically when we're talking about using Zepatier, if a patient has genotype 1A, to run that baseline, we say, oh, NS5A polymorphism resistance testing, blah, blah, just spit it off and keep going. The other instance that we tend to bring it up is with genotype 3 patients who have liver cirrhosis. We should be checking this baseline resistance testing. And what this is in certain populations really testing for these pre-existing, so baseline resistance associated substitutions, it's warranted prior to the use of certain regimens. And the why is that if you recall from when I was talking about this, given this talk a couple months ago, you know, hepatitis C, it replicates crazy rapidly. Billions of viruses, virions are replicated or produced daily. And so the polymerase enzyme associated with hep C, it doesn't have that proofreading ability. And so that's actually fortunate in many instances, because a lot of times it renders the progeny virus faulty. So it produces a lethal mutant. Either there's something that's glitched with the genome that it can't reproduce any further, or it renders a non-functional genome, so that virus just dies. In certain instances, though, those errors or mutations actually occur in a critical coding region, and to where they can mutate and actually cause a resistance associated virus. And so that's why when we say, oh, you need to do that baseline testing with Zepatier with a genotype 1A or genotype 3 with cirrhosis, it's because there tend to be higher rates of those pertinent or critical substitutions, either using that drug or using Epclusa, for instance, with genotype 3 with cirrhosis. So in some cases, they actually can render our direct acting antivirals less effective. And so the testing for, it's typically, we say NS5A resistance associated substitutions. This test is really hard to order. Most likely you're going to have to call your lab and ask how to order it, because you either have to put it as a help lab or code it a certain way, or they have to help you with it. There's got to be, I think it has to be frozen and spun down. And so, you know, this is something that if you're planning on checking this on a patient, go ahead and call your lab ahead of time to make sure that the specimen is collected properly and ordered properly, since we don't do it very often. So we tend to talk about getting NS5A polymorphism test. There's also the NS5-3 polymorphism that you can order as well. So if you're using like Mavrit, for instance, or another protease inhibitor, you know, you may get the NS3. So if they had like a treatment before with Mavrit, or even with, I'm trying to think, Zepatier in the past, or Vicirapac, then you may want to get that NS3 polymorphism testing, not just the NS5A. Okay, and so this is really important in determining if we're using the appropriate treatment regimens for people who have either failed prior treatment with interferon-free regimens. So you don't necessarily need to get this if they've been interferon experienced, or even the older protease inhibitors, the first generations, you don't need to get this. This is really just with these cases of treatment failures in the newer drugs, or in those special instances, like I said, where that baseline resistance could have occurred. So next slide. So I got this on this guy. Oh, okay. So the presence of the RASs like really can help determine, you know, if your regimen duration needs extended. Sometimes you might extend it from 12 weeks to 24 weeks. Sometimes you'd add ribavirin instead. And so think of this as these substitutions, they're not making the treatment, hep C treatment itself, ineffective. They're just lowering your probability of that treatment working. So whereas we say, oh, okay, broad scope is these are 98% effective. And in patients that genotype 1A patients necessarily that you might use Zepatier for, that have certain substitutions, you know, treatment may only be 50% effective. Or in our genotype 3 patients that have certain mutations with cirrhosis at baseline, even if they're treatment naive, if they have certain mutations, treatment with Epclusa or standard DAA courses may only be 30% effective. So it's not that it's not effective at all, it's just you're really, really lowering that likelihood to where you might have to make adjustments otherwise to increase their probability of sustained virologic response. So go ahead, next slide. So I got it on him, and his NS5A testing showed he had this Y93H mutation, which that's the one I think is the most important, because that's the one I believe we see most commonly with treatment failures. But as you can see, it actually interprets it for you. You don't need to memorize the mutations or anything. It conferred that he had probable valpattinosphere, which is the NS5A inhibitor in Epclusa resistance, and then also declatosphere resistance, which was an older NS5A agent that we don't tend to use anymore. So yeah, so I don't know if this gentleman failed because he had this baseline testing and I just resistance, and I just didn't bother to check it first, or was it that, you know, because he had that lapse in treatment, you know, if you've got really subtherapeutic levels of these Hep C agents while they're on treatment, those resistant or mutations actually have better selective fitness. So they'll actually could be the dominant species. And that's why the treatment would fail. So that's why we really push for make sure that they're taking those drugs, all doses, same time every day, is so that they don't end up with those subtherapeutic levels to where the resistant virus can kind of dominate, if that makes sense. So next slide. Okay, so I think I kind of just already harbored on this, but yeah, so just remember that to make sure that you're genotyping, since we have these pan-genotypic agents, you know, genotyping isn't as important anymore, but you know, for insurance purposes, we still have to get it, or because they require it. But in these instances, it is. If you have a patient who's cirrhotic, you need to genotype them if you're using Epclusa. Genotype 1, I think I told you with Zepotir, we need to make sure to genotype. And then at treatment experienced patients, make sure that you're genotyping those. Okay, so next slide.
Something too.
Yeah, go for it.
Yeah, the other reason, and I know you and I have talked about this on occasion, genotypes are still important to check in case of reinfection or treatment failure assessment. So if you knew that, we've actually had this happen where we've treated a genotype 1 or something, and then we thought there was treatment failure because the patient had recurrent viremia, but then they had a different genotype. So anyway, one other reason that genotypes would be important.
Right. Yeah, and I guess, yeah, so I should have clarified that. Yeah, because I can go back through some of the other reasons, you know, that from the first half of this talk that we talked about. But yeah, so from reinfection standpoint, it's important to genotype. Even from an epidemiological standpoint, you know, it's good to genotype, so we just know, because there's certain geographic distributions of the various genotypes globally. And so that one thing that would be important to kind of consider is that with our Hep C elimination strategies. So, you know, we tend to talk about, oh, well, we can't get a hepatitis C vaccine because this virus, it replicates so quickly and there's so much heterogeneity to it that we can't develop a vaccine that's really going to target this virus. But in certain areas, like in Egypt, they really have predominantly genotype 4. In the US, we see typically 1, 3, and 2 are kind of the most common in that order. But in places that really have very minimal heterogeneity, you actually could theoretically develop an effective vaccine for hepatitis C, since you know, if it was targeted just for that genotype. So yeah, there is still utility to doing it. Now, from an elimination standpoint, as far as a strategy, since we're seeing most, you know, new infections with Hep C being these younger patients, the injection drug use, it's 20 to 39-year-olds are really the ones that are kind of carrying this infection forward with forward transmission. You know, certainly with reinfection, that's one thing. And in West Virginia, that's unfortunately a limitation because of retreatment. It's hard to get retreatment covered. But to be honest, if we're talking just purely, if we had all the resources in the world and we could just treat everybody for Hep C, the reinfection rate is very low. It's less than 5%, even in patients that continue to inject. And so you wouldn't even necessarily have to, if you're using a pan-genotypic agent in, you know, a young adult that's probably just had this virus for a couple years. And you're just trying to get them on treatment to get them cured and to reduce the risk of forward transmission. And that utopian world, we wouldn't even really have to genotype those patients. Does that make sense? It's not what our practice is, but I'm talking kind of theoretically. Why we do it, doesn't necessarily have to be applicable in all situations if we didn't have to worry about certain limitations or access to treatment, because there's a lot of states that don't have that restriction. All right, anything else? Anybody want to make comments? Nobody.
Yes.
Yes, please. What
Hey.
else?
It's just about fibrosis stuff.
Yeah, do you want me to go over that again?
No.
Oh, okay.
I wanted to share something. Not that I loved it, but by the way, this is John. Anybody who didn't know. To the Echo people, to Jay or anybody, can I share my screen for a second?
Yeah, we'll give you access here in a second.
Thanks.
Yeah,
You're
let me
good.
just stop sharing this one. Is that okay if I just stop here then? All right, you should be good to go.
And Kaylee, were you done with the PowerPoint part?
I think.
You can have it back, like the share screen part.
I actually don't think. I think everything that I was going to summarize, I kind of just rattled off a second ago. So I think we're good.
Thank you. Hey, I wanted to show something about fibrosis that has been tricked me twice in 1 week that maybe hasn't tricked anybody else. But okay, can you guys see that?
Yes.
Yes.
Okay, first of all, the most important thing on this one is this is from an alternative Project Echo site, which is awesome, number one. So, and it's from my home state, University of Vermont. It has the most dairy cows per human ratio in the country, if that ever shows up on a trivia question. But what I actually wanted to bring this slide up for is I have been seeing some elastography reports come through without kilopascal reading. And so I basically saw a report that said the median, and I didn't read the values, it said the median blah, blah, blah was 1.7. And I was like, oh my gosh, that is an incredibly low elastography reading. And basically it was very comforting, and I didn't bother thinking past that. But what I want to point out is not the thing in yellow. I'm not sure what the Echo group here was trying to emphasize, but just know that there are different machines that are now giving readings not in kilopascals in this fibrosis score of M per second. And I don't know the physics behind it. I don't even know what it stands for. But so the one that I saw earlier this week that was 1.7, that if it was in kilopascals would be ridiculously low, was actually in this meters per second. It was a Siemens machine, and I actually would have qualified it as F3. So I just wanted to bring this up, that I know we've literally, for as long as we've been doing Echo, we've only talked about kilopascals being the unit with which elastography is reported, but there are more and more machines now out there, including this machine was in Garrett County, Maryland, at a small community hospital up there that did the meters, did the M per second. So this is purely just an FYI to pay attention to units.
Glad you brought that up. Yeah, Garrett County Hospital. That's what they use their meters per second. But because remember, there's different elastography machines. There's a shear wave, there's a transient, and so the way that they're measuring the sound waves in the distance is different. So I believe that the meters per second, that interpretation should be a bit different.
Yep.
And I believe that we tend to use the transient elastography, which is in kilopascals, and a lot of the staging criteria. So I don't know if we can bring my PowerPoint up, but I had a slide that was just on the elastography, but it was the transient elastography, and how even with different liver disease processes, that measurement, the range of it, I think it's slide 16, maybe. It was like a big picture of a liver and some stuff. Yeah, that one. Yeah, so that's the transient elastography. And so that one measures in kilopascals. And so anything greater than 12.5 is really suggestive of cirrhosis, but you can even see through the varying disease processes, the cutoffs are different for what they term, advanced fibrosis or cirrhosis and whatnot. And there's a lot of this exam can be influenced by several things too. So an obese patient, there's a lot more tissue, fatty tissue to get through. So you can have, inaccurate measurements in obesity. If somebody eats a big fatty meal right before this test, it can influence it and give it an overestimate. Hypertension can even give it an overestimate. So, this isn't a perfect exam either. So again, that's kind of why the case that I presented, we had some discrepant values. And so, really using that clinical judgment and the clues that are on the imaging itself, rather than just looking at the number or looking for cirrhosis or not. So if you see things that suggest that portal hypertension, like there's any kind of dilation of the portal vessels, or there's that portosystemic or collateral circulation, then that's very highly suggestive of or indicative actually of cirrhosis. And so you don't even need any other measurements if you see that on there to tell you that they've got advanced cirrhosis. You can go off of that. But none of these tests are perfect. APRI, FIB4, fibro test, the elastography, we kind of use all of these modalities to give us a probability of how much fibrosis is there. And then from that, we gauge, well, now if we determine they have cirrhosis, are they compensated enough for us to treat them in our setting, or have they decompensated to where that needs stabilized first? Who else has questions? Because I don't have anything else.
Haley, that was terrific. Thank you so much. I really appreciated you going back more into detail about the resistance testing, because I have heard you guys talk about that, and I, at the time, was fuzzy on it. So that was a big takeaway for me. I really appreciate the case and the didactic.
Cool, thank you. No, I appreciate you guys listening today. Yeah, and I mean, we don't need to use it out as often. Remember, it's not something that's going to render the medications ineffective. It's more so that it's just decreasing the probability that they're going to achieve sustained virologic response. We have so many agents now. So when we only had Harvoni and some of the older PIs, we kind of, had to pick and choose, okay, of these, which one is going to give us the highest likelihood that someone's going to achieve SVR. Now we have such high success rates that if we do have some of that resistance that shows on that testing, you usually have another option you can use. In this gentleman's case, I honestly would have used Mavorite in him if it had been available. His disease was stable enough. But if I hadn't have gotten that testing, or even if I had, now since he failed treatment, he would actually be a treatment failure now that he'd had that full course. His really only retreatment option would have been Vosevi, and then actually in his case, since he was cirrhotic, would have had to add ribavirin too, to really increase it enough for him to have the highest likelihood of sustained response. So just bringing those up, because we don't really present too many cases like that, and it's easy to forget.
That was my question on him, was whatever happened with him. So
yeah, unfortunately, so we had actually deferred retreatment on him, mainly from a logistics standpoint. So he was a Medicaid patient initially, and then so his facility would have had to assume the cost if he was going to be retreated. Plus, he had been kind of refusing blood draws. He'd not. I don't want to say he just wasn't really stable enough. I didn't think we could get him through a course of ribavirin and him tolerate it or want to continue it. Now we have more data to suggest, well, you could still do, Epclusa for 24 weeks and still have about an 84% response rate, which is, not terrible. But unfortunately, actually, I just pulled up his chart today since I hadn't reviewed him for a couple years because he never came back into care, probably for the last 2 years, but he actually passed away from a esophageal cancer. So he was not somebody that, yeah, they just did palliative treatment and he had a big mass. So yeah, he didn't end up getting treated again, but did not die from his liver disease. So anything else, you guys, or anything else you guys want to talk about, since we don't, we don't really have anything planned as far as cases today. So if you guys have any questions, generally speaking, or want to bring anything up, go for it.
Thank you so much, Kaylee. That was wonderful. Great continuation and very knowledgeable. And I think everybody can say they really appreciate that. Thank you very much. Does anybody have any comments, questions? And you can relate to something else, as Kaylee said, since we don't have a case, we have a little bit more time, or you'll get time back. So it's up to you.
Which is always a great thing too. You guys want to have a lunch break? Finally, a lunch break, actual break.
Celebration, I like that actually. Yeah, the smoothie, but I have to have some more. Like, I'm just gonna have salad, like just not enough. Like, I really try in here, but I get hangry really, really soon after. Well, if everybody's okay, I'll just make that announcement for everyone. Our next session takes place on June 10th with Gene Kernel discussing right upper quadrant ultrasounds. So thank you everybody for joining us today, and I look forward to seeing you again. Bye-bye.